interventional radiology emergencies, and here are my disclosures. I know, we're all going to learn together, but to do that, we have to set the sort of the discussion. So the purpose of this talk, we're going to assume that you know how to do the procedure, okay? Or you're going to look it up after this. And I'll show you a case. You don't take it like the board exams or anything. Just, it's not supposed to be a trick. You just say, and I wouldn't even pick on anyone. I'll just hope that someone is going to volunteer. If not, then I'll move ahead and just discuss the case. Then we will focus on what would be medical decision making. One of the things about the training today is that we know that you don't always, most of the sites don't have night float or night call. And so imagine it's 3 a.m. and someone is calling you, and what it's going to take Besta or any of the techs and the nurses to come to do your procedure. So just assume that mentality as we go through these cases and decide, do you think that this patient can wait till the morning? And what's the risk of waiting, and what's the risk of the procedure? And so that's going to sort of make you think, what makes this an emergency? And I hope by the end of this talk, you're going to sort of understand how to interact. This is not supposed to be for passing exam. It's just to help you say, oh, when I get this is what I would do different. Now, even if today we'll be trying to use at night, it's just because it's special conditions, but this also has to happen during the day because we have limited resources, and we'll be discussing some of those things. And also sometimes in these emergency cases, we have, special considerations, like should you get more imaging? Are there any other I want us to discuss any pre-procedural preparations, anything before cell thinker when you start sticking. We are not going to be focusing on the technique. And then what happens when you have two patients and you only have one room, or you only have one PCN, or one biliary drain? How do you decide that? And then where is this patient going to go? Are they going to go to home? Are they going to go to the general wards? Are they going to go to the ICU? Also recognizing that it's not like we have a lot of these ICU resources everywhere around the world. And so, and then when should you call for help? You can call for help from another of your colleague if you're an attending, or you can call for help from a different specialty, or do nothing. And so I'm hoping that that's going to be our discussion today. So I'll start off by saying, anyone wants to help us with this? You can just read it on your own. But I'll read it just to give people some time. So 67-year-old male with pancreatic cancer had PTBD, placed 6 weeks ago, presents with 24 hours of fever, right upper quadrant pain, and decreased drain output. Patient is on chemotherapy, and the vital signs are as shown, and also the basic labs are shown. Anyone wants to try and tell me how they would think about this to get started? Janice Newsom. I'm kidding. Okay, so no volunteers, so I'll just go ahead.
I will take it. I will take it.
Okay, yes, thank you.
So with that clinical presentation, so I would think this patient has cholestasis, despite that he had PTBD instated like 6 weeks ago. So given that he has fever and pain and decreased the drain output, that means this patient has cholangitis. So the possible reasons of why the drain has decreased in output. So it could be the drain has been pulled out, or it has dislodged, or because of the peristalsis, the tube has been pushed more towards maybe the jejunum, or it has clogged, maybe it wasn't properly flushed, it has closed perhaps. So the first thing that I would do to this particular patient is do maybe a chest, an X-ray of the abdomen to locally to localize the position of the tube. And then I would prepare this patient to go back to angio. So we'll have we have a total bilirubin there. We need the INR is fine, and the WBC is elevated. That means this patient has ascending cholangitis. So this patient has to be taken in angio for possible tube revision. So under septic technique, we'll do
that's perfect. Don't worry about after you're in angio, we stop. Excellent discussion. So my question to you is, if this is at 3 a.m., are you going to do it in the night or during the day? Or you can say, let's wait till 3 days later.
It's an emergency. That means the patient has to be taken to angio right away.
Okay. Would you do it at night? Like 3 a.m.?
I think I would do it. It's an emergency. Yes.
Okay, great. Okay. Okay, so as you mentioned, the tube can have gone way further. This is the last open side hole for these tubes. I know you do have a lot of tubes that you may not have anything. So this is a scout image with injection, and you can see that this part of the tube is open up to this radiopaque marker, and then you see some contrast that ends into the duodenum in this case, but the tip of the tube is way lower. So all these segments, right, there's no hole unless someone had created extra side holes that are draining this. But so when it comes to thinking about tubes and lines, so for this one, right, there's no hole and you should change it. Most of us will not come in at night to change this tube, but we will prioritize it in terms of urgency, right? And so your answer is correct. This is a very sick patient. They can start treating, they can start to give antibiotics, right? This is a patient who already has a high heart rate, the blood pressure is going down, so heading to a septic picture. So very, very sick patient, and you should prioritize on managing the tube. Now, in this case, the example that I show is pretty exemplary because you can tell that there's no side hole that is draining in the liver, and if the tube had a side hole open, what you would do is just go see the patient and open the tube to bag. So you make it an external drain instead of an internal external biliary drain. And so that usually will come with a lot of output, but it also helps you troubleshoot. I forgot where my picture went, where I found that the tube, the off side was to the patient. So the tube was actually okay, but just not draining because it was closed. And so laying your eyes on the tube and just trying to figure out what's going on, trying to also, if you can, get the KUB, especially if you don't have enough, sort of like time in the angiosuit. Some people, can help you see exactly where is this tube. You can look at the radiopaque marker and you can compare. I know we don't still save the images for this. You can compare with the original one where the last marker was sort of left. And so in terms of, if I go back to this, so would you use any, hopefully the patient is on antibiotics, but I just want you to remember that. Do we need anesthesia for this patient, or how would you manage the sedation?
Most of the time we do them under moderate sedation, which is sometimes the nurse will do that. Mm-hmm. But I think if we have an anesthesia person, that would be an added advantage.
Yeah, so just be careful about sepsis because everything can shut down, but this you can just do with local, right? You just want to exchange a tube. But just the moral of the story, this example that I put here is, a little bit requires you to recognize some things, but tubes are very urgent, especially when you have this type of findings. But at the same time, remember, you can also externalize, just open it to a bag, and that buys you time. So that you can wait a day or two actually for them to stabilize the patient. Okay. Any other thoughts? We have many attendings. I see Aza, Newsome, many of them. Any thoughts about managing tubes? Okay, cool. We'll move on to the next case. Anyone else wants to try this one? Oh, one more thing on the last one. You also have so where you have a ton of resources, like where I work right now, we usually change these tubes, and it's our guidelines to change them around every 3 months. And so if you have a patient with presenting with cholangitis and they already have a biliary tube, you also have to figure out why. Just the same way you said about flushing the tube, also check the frequency. Some people are just trying to tell you, I cannot wait for, 3 months to exchange. So you then tell them to come every 2 months. And then also, just make sure that the technique of flushing is correct, especially for these biliary drains. Remember, we just flush forward. We don't flush and like irrigate it, because you're bringing things from bowel through the tube. And so that can increase the risk of infection. When you go to
Sorry,
Yes,
Judy.
no, go ahead. Yeah. Mm-hmm.
No, I just remembered something that I think of note, people have to note that it's not, and you need to figure out like why the patient has sepsis, because sometimes it's not always the tube's
The
fault.
tube.
Like
Correct.
there could be other causes too.
Yes, absolutely. And that's why, for most of us, we will investigate the tube just as you discussed, see the patient, but we don't really, this is not something I would call the team at 9 a, like 3 a.m. to come into the hospital to do a tube exchange. Remember, there's no like absolute nevers, but that's my medical decision making. Anyone else wants to take this one?
Yes, I will take it.
Mm-hmm.
58-year-old male with end-stage renal disease on hemodialysis, with the right upper arm AV graft for 2 years, but presents with the dialysis unit after the staff unable to access graft. Patient notes the graft feels different since yesterday. Last successful dialysis was 2 days ago. Presentation, the symptoms are there's no brood or thrill over the graft, and it is firm and non-compressible with mild arm swelling, no pain, no signs of infection. The labs, sodium, potassium is elevated.
And you can, yeah, okay, good. That's what I want. I just want you to say the abnormal labs or what's.
With the presentation, history and the presentation, I feel that the graft is thrombosed. There is thrombosis of the graft because we don't have the bruit or free over the graft.
Is this an emergency or not? In this case, what would you do?
2 days, it does not feel emergency.
Okay. What makes you say it's not an emergency?
I would consider it a priority that within 2 days, it gives me the room to intervene the thrombolysis because it is still acute, but not an emergency like in a few hours, maybe life-threatening. It's not life-threatening. Okay. That's my line of thinking.
Yeah. Is there anything that you would offer this patient?
What I would offer this patient?
Look at the labs.
Yeah, the potassium is elevated. So I would offer maybe a temporary line, central line for dialysis while we are working to salvage the graft.
Okay. Someone may ask you, why, if you're going to bring the patient to angio, why can't you just fix the graft immediately instead of putting a temporary dialysis line? Or when would you put the temporary dialysis line? You can call a friend. I cannot see the room, so I cannot call anyone too, but
Okay, I have a friend here.
Maybe friend can that was everyone from moving on, just say your name too, so I am not randomly.
So this is Manabasi. So okay, since the potassium, this patient has hyperkalemia, so it's a risky patient. So since we may be able to put a temporary catheter, maybe in angio, then we may be able to try and salvage it. If the graft won't be salvageable, then we may need to put a permanent catheter.
Okay. So, any other thoughts? So, when we think about, so this is this is a Fogarty balloon trying to remove the clot. This is a thrombosed graft, and you can see also there's some clot. But once you clean up, your graft, then you come back and open the arterial side, right? This is almost the last step you do after you've resolved everything. You've removed clot, you've resolved the primary problem that's causing the graft to go down, and then you pull the plug. That's what this is, and that opens the graft. So one thing that is around hyperkalemia, this is just a quick review, right? So most of us just at least in the hospital I work, 5.5 is the nurse will say I cannot sedate the patient. And so usually this is the guideline from like American Family Physician. I put it here just to remind us. So potassium of 5 to 5.9, evaluate cause. In this case, you know that this is someone who skipped dialysis. And then if it's more than 6, you should do an EKG. Now, remember, we may not always have these things, but even if you don't have it, you still have to learn the right thing, And so because the risk here is, arrhythmia, right? So if you have EKG present, you give calcium to stabilize in addition to this other medication. If you do not have, EKG changes, then you consider dialysis, which is where we come in and try to provide access. You can have continuous monitoring, and you can also administer insulin. So then you keep monitoring. Now, this is the textbook version. No one in Kenya or Tanzania is going to run potassium every hour for you. And so you kind of have to try and do this with more permanence. And so if you, potassium gets low, then you return to A. But then if yes, then you can sort of address the underlying cause. So this potassium of 7 has to be addressed. And here are some of the medications. In the acute treatment, you give calcium to stabilize the membrane and reduce the stabilizes the cardiac muscle cell membrane. And just remember, these acute things have no effect on the total potassium. You're just shifting it. And so just be careful, because if you say I'm going to be giving this for 2 days, then your potassium is still in the body. And the one thing that lowers the potassium is kayexalate, and this you have to poop, and so it takes time for you to act. But in the emergent setting, this is calcium, insulin, and albuterol. And if you're under anesthesia, they can hyperventilate the patient, which also helps with sort of blowing off some air in terms of reducing potassium. So this is a good sort of review, it's an easy read to read. But going back to IR, then you have to think, okay, when I get this type of patient, what I do is, if their potassium is high, right, I start off, let me go back. I tell them they have to correct the potassium, because if you're doing thrombolysis, you're going to be breaking up the clot. You're going to add more potassium burden to the body. And this is why you should not because of, you say, oh, I can wait. There is an emergency here, but you need to medically manage the patient and provide a way of managing the excess potassium, which usually will require a temporary dialysis line to allow for treatment and stabilization, so that you can come back and do your procedure. The second thing, I do have a companion case for the same one. Just asking you, what if the thing that they present with everything the same, potassium is normal, so you could go ahead and do you can go ahead and do the procedure, but these are the vital signs. Would you change anything? Let's say if there's the temperature is high, if there's a concern for infection, would you change anything that you're doing? Would you wait?
Maybe we can add on top of that blood culture and sensitivity to rule out if this patient is septicemia, And however, we should start immediately the patient on antibiotics, and then later on we can change them according to the calcium sensitivity. However, we'll proceed with the decision that we have come to reach.
So yeah, so this is a little bit challenging. If there is concern for infection and there's no other sign of infection, some of us will still do ultrasound on the graft just to have a look. You cannot see infection there, but if there's a concern when you inspect the skin and it's red and there's a concern for graft infection, then you should not do the procedure. That should probably be done by vascular surgery who can open up. And this is because you're breaking clot and you're sending it everywhere. And so you could have sort of, it's like infected clot going everywhere in the body with a risk of endocarditis. Any other thoughts about emergencies in terms of renal dialysis? Haza? Okay. So, okay. Everyone can feel free to sort of add anything that they think that we are missing. Okay, we have another case here. If I can either take them or I would prefer not to, but if that's what has to happen, I will.
Yes, I'll take this.
Who's that?
Agbola.
Okay.
This can cause Matatu.
What's Matatu? Anyway, how do you evaluate this?
So the first thing is to confirm if the tube is still in place. So, because this is an accidental issue, so the PCM could be dislodged. So I'll first ask the patient if the PCM is it draining, is it actually totally dislodged or not. If subsequently I can now also physically examine it myself, and then I can take out the ultrasound and try to do the ultrasound scan, looking for the access site, tracing it down all the way to the tube and into the kidney, and I'll get a 10cc normal saline, try to flush it and see if it goes through. Before that, also should go actually the issue of the material, blood stained urine, also supporting possible displacement of the tube.
So I think you're getting a sense of some of the things in emergencies. If you can, and you should try to, you should really be at the patient's bedside. It's going to tell you a ton of things in radiology, in IR, not radiology. Radiology can look at the images, and it's going to allow you to also just teach your mind to sort of help. And sometimes you also help with other things, for example, getting access and something like that. Now, this is like I showed you previously on the biliary drain. This is the radiopaque marker. You could see maybe this is trying to be uncoiled. Just remember to compare with the old images. Hopefully this year we'll try and make sure that all images can be viewed when they're stored. And so when you look at this retracted tube, just like you mentioned, you assess it, you ask for urine output, you look at the color of the urine, right? And that can also help you figure out, for example, if this is a tube that has been there for, a year and now there's frank blood coming out, that raises your concern. You inspect. Also remember that as long as the integrity of the tube is there, most of the time the inner lock can still work. So sometimes it's just the suture that's out. And then there's a big role for imaging. I know that we rely a lot on sort of ultrasound for evaluation, and just remember that there is some imaging. I think most of us would not do an ultrasound just because it's a lot of work, and you guys tend to be better than us for those. But a KUB, you compare it with the previous one. Just remember with these tubes, don't push it back in, okay? Because this has been in the outside and now you're pushing it back into the body. I think sometimes that's our natural thing. Now, if you could pull a tube out like that biliary drain and just sort of, but really the best practice is not to try and push it back in. And that's our like our natural habit. So this should also apply for vascular access and all these other things. Just don't try and do that. And then one thing that I prioritize, so this is not an emergency, just to me, like I mentioned in terms of the biliary drain, is I do prioritize these patients to go fast, especially if it was a very difficult, challenging case and the tube is just barely hanging out, because changing a PCN tube is much faster and easier than trying to put a new tube in a non-dilated system. So I make it urgent, not necessarily that I'm going to call Fabian to come in the middle of the night to exchange this tube. Remember, it's the same issue like if someone comes in with, like urosepsis, just the same things, like, as I said, make sure that, that the tube is open to bag and that urine is coming out, and that you're not really, sort of, that people sometimes see your tube and they blame it, and you have to work it up. And sometimes you also have to change it so that they can move on to work on another diagnosis for the patient. Here's a companion case for right flank pain. What's the diagnosis here?
Okay, Manabasi again. It's a CT contrasted arterial phase, axial view at the level of the kidney. So we have dilated calyces and renal pelvis on the right side. So giving the history of right flank pain and imaging finding of dilated renal collecting system, I would think this patient has a urosepsis. So it's an emergency. And we will, however, complement it with lab finding from the that picture.
Okay. So remember, you cannot tell sepsis from imaging, right? What makes a patient septic? And I gave you a clue with the biliary drain case.
Okay, so fever, they would have fever. Vitals would be hypotensive, tachycardic. And if you do a full blood picture, you would have elevated white cell count with predominance of neutrophils.
Okay. So there's a sepsis criteria. There's quite a lot of debate, especially for the application of this sepsis criteria in regions that are where the data was not sort of collected from. For example, should you use the sepsis criteria made in the US, in Africa? That's one of the things. But remember that you have SARS criteria, and that's temperature more than 38 degrees, heart rate more than 90, respiratory rate more than 20, and WBC more than 12,000. So you meet more than 2 of those criteria. Then sepsis is you have SARS, those changes under suspected source or present source of infection. And then you have severe sepsis and then septic shock, right? So when you septic shock will be the change in blood pressure when you have hypotension despite adequate fluid resuscitation. And then you also have MODS, which is the evidence of more than 2 organs failing. So this is a spectrum of a disease. And when you miss one, people get into a cycle and move on. And so I'll send this again to you, just the criteria, and just be aware of that. So we try to catch patients, especially in SARS, when they're in the SARS criteria. And that's where, if you're in that phase, you're responding to fluid, someone may decide, I don't want to, I'm giving these examples at night just because then you have to make a decision, not just for the patient, but also in terms of the resources and the support you have. And that would not be if you find someone in urosepsis, like in septic, specific urosepsis, then you should be trying to intervene on, because they can rapidly progress. But you may find someone who came in, they just have tachycardia, but they're responding to fluid, and you can just wait, a few hours, and you've started antibiotics. What characteristics does volume matter for hydronephrosis and making it an emergency? For example, small, when you put your ultrasound, small, moderate, or severe hydronephrosis. Does that help you guide to decide whether there's an emergency?
I'm not sure, but I don't think so. But I'm not sure.
Yeah, so this was one of my first lessons at 1 year, where people thought that the volume correlates, like, so look at the labs, look at not just the sepsis, but also potassium. Now, when you have 2 kidneys, remember people can donate 1 kidney, or some people receive 1 kidney and they do okay. You have to be sort of careful about the rates of development of hydronephrosis. For usual patients who have cervical cancer, their hydro develops very slowly. And when it does that, then your body sort of tends to compensate. When you have this, you have prostate cancer, then your body tends to compensate and develops this potassium very slowly, but the potassium accumulation. So you may not really see a big bump or not a potassium, creatinine. You may not see a big creatinine bump or, as more than someone who's just had an acute event, for example, injury, that then you find a big elevation of the potassium. So volume doesn't matter. What case would it give you? What would make this like an emergency, like on imaging? So you cannot really tell sepsis or lab changes, but what would, not this specific case, but what would you see on imaging and decide, wow, this needs to be done urgently? On
This
the
is Eva.
Huh? Yes, Eva.
I'm thinking the differential attenuation of the kidneys would make me want to do this faster.
So try not use this specific case. So if you found air, right? When you starting to think, because that is trying to tell you, hey, this is a little bit just most likely, pass when you have extreme stranding around the kidney itself. Those are some of the things that could give you a proxy that something else is, this is not just your usual hydronephrosis that is just developing around the kidney, and you should prioritize this. Now, there is another reason. For example, this was the case that we had the first time, and just trying to move away from trying to say a volume of like severity of hydronephrosis. And this was, the patient is anuric, because then the labs obviously are changing. But if the patient is anuric, which means that they cannot pee, and because of the obstruction, then you have to relieve the obstruction, unless you think that use of like putting the patient on dialysis, where most of our patients would not even be able to be put on dialysis, is the next thing. And when you relieve the obstruction, you do see an improvement in this. Okay, any other comments or questions around tubes and emergencies? Okay. Cool. We'll move on to our next case of this one. Anyone wants to try?
Eva again. Yeah, abdominal swelling.
And if I don't know if you were on when we started, it's not an eye test. It's just, I want us to discuss the medical sort of decision making before the procedure. And does this make, let me just quickly show those slides in case I don't forget where I am.
Yeah, so this is a sonogram with fluid in the peritoneum.
What's the procedure being done here?
They are doing a paracentesis.
Okay, is a paracentesis or any fluid management an emergency?
No, I don't think it is.
Okay, why is it not an emergency? How long can you wait?
Okay, so it depends. If the patient has if the patient is infected and they have Is that better? There's a lot of echo where I am, so I'm not sure what everyone is hearing. But I was thinking if the patient has infection, then I would want to do it more urgently, as opposed to if they've been with their fluid for a long time, and they're not overly distended, like their breathing is not compromised. So those are the things that I would look at to consider whether to treat it as an emergency or not. If the patient is so distended that the fluid is pushing on their diaphragm, they cannot breathe well, then I would want to do that more urgently as compared to a patient who has fluid, but they are very well compensated.
Okay.
And then, yeah, so patient comfort, infection, yeah, those are the two I can think of now that would make me consider it a more urgent procedure.
Yeah. Okay. Yeah. Great. So this is same thora, para. Most of us will look at the volume. Also look at the history. This is for example, patients who always come with cirrhosis, who always come for fluid management. Then they know their sort of volume, and usually you can prioritize it, especially when there's extreme discomfort. But I personally don't try to do it emergently. Now, when it's an infection, is that you can really prioritize this to get a sample when people are trying to look for a source of infection. But even the worst, the most common, and the sort of like the infection when you have cirrhosis and ascites is spontaneous bacterial peritonitis. And usually, they just start on the patient on antibiotics. And so thora, the same, when there's very, very large volume, remember the rate of accumulation matters. If it's like trauma and you're bleeding, it's a hemothorax. Now remember, that's why they put the big chest tubes to try and suck the fluid out. Then the symptoms are much more severe and the patients may require, sort of airway management. So I think of my role here as supportive. I wouldn't wake up everyone at night. Remember, this can also be done at bedside, and that's also the location of the procedures is something that you need to be thinking about as you see them. So at 8 a.m., Kubwa drained 5 liters of straw-colored fluid. Patient went back to the ward and passed out going to the bathroom. And what's the diagnosis here? I mean, there's an angio, so hopefully. Okay. So this is, active extravasation on this CT scan. So you can see contrast here in the iliac vessels. And so you can see there's a blush here. You can see large volume, fluid. Definitely the patient has an Asaka, and this is different density. So this is, blood products. You can see that there's a shift here. I'm coming from the right side. We're coming from the right side. And sort of when you're thinking about the inferior epigastric, it tends to be more medial, but when you have a big hematoma, it can be pushed. But the reason I'm showing you this case is to discuss bleeding in the set of emergencies. Is bleeding an emergency, and what sort of bleeding is not an emergency, if there's anything like that?
I think you have to characterize in terms of venous and arterial. Venous can be forgiving, and you can do watchful waiting, but arterial is emergency.
Okay. How about location? That's a very good, like if it's in the thigh or in the back. So, and this maybe predict the question that the answer that I want, but so location also matters, right? So if it's some subcutaneous, something in the subcutaneous tissues, people will wait for that. I do have another case here for bleeding, and maybe I'll jump there. Even in the case of you look at the hemodynamic stability of the patient, please remember to review the medications of the patient. And this is because if you don't review the medications and they're beta blockers, the patient can sort of fool you because you think that they're well compensated, but they really are not. Usually now I've moved to using the shock index, which is the heart rate and, over the systolic blood pressure. And if you have a high shock index, that means, the patient is really not compensated as much as you think. There are other reasons that you can do an intervention. And this is just deciding if you have two people bleeding, which one do you do? And most of us have been in this situation, especially as medical officers, where you have two moms delivering and they need cesarean sections. You have to decide which one are you going to take. And so you look at stability, you also look at resources. We do know that blood in Africa, most places is still whole blood, so it's not really packaged separately. And sometimes you have to ask relatives to donate blood. And so you may not have the type of blood resources here where you have massive, you can do a massive transfusion protocol. And so that makes it very difficult. So I think about also guidelines. For example, in our institution, there's some things like pelvic hemodynamic stability in a patient of trauma with pelvic fractures. That's that's an emergency. Actually, it has to be done with, you have to be doing the procedure within 1 hour, and that determines sort of the trauma certification. So it has consequences for that. Also, high-grade splenic injuries, especially 4 and 5. And so if you sort of look at the guidelines, look at the location, look at, is it arteriovenous? So in that case for trauma, I don't bother, once we just see, I don't bother trying to, I look at the images to plan, but I start activating the team early when it's confirmed as that type of blood. You can also look at resources to preserve blood. And then some of the locations, I can see some bleeding, and then just say, oh, this is okay. Now, the bleeding that I can wait tends to me to be, for example, it's not really bleeding, but a place where you'll do an angiogram for bleeding. For example, if a patient has had an endoscopy, they have clips, and they need it's a situation where there's a need for prophylactic GD embolization, then that I can wait to sort of do it in the daytime. Here's a companion case for left groin pain after biopsy. Do we think that this type of bleeding, I hope you can see this big pseudoaneurysm here in the left groin, is this an emergency or not? We only have 15 minutes. We just have to run quickly through the cases.
Yeah, Eve again.
Yes.
I don't think it's an emergency.
Okay, yeah, right. So these pseudoaneurysms, usually we can wait and just treat them. Remember, waiting is also part of the treatment protocol, right? And so how about this other patient, 56-year-old, presented with abdominal pain with incidental findings on imaging. I told you these are not eye tests, so here's the finding that I want us to focus on. What's this?
Yeah, Eve again, this is a right renal artery aneurysm.
Mm-hmm. What's the difference?
I think there's a criteria. There's
the
a cutoff at which you should treat.
Mm-hmm.
I need to check.
Okay, so what do we think is the difference between the aneurysm and the pseudoaneurysm, right? So this is a pseudoaneurysm that we had to wait for, and here is an aneurysm. Is this an emergency or not emergency? When you see this, are we activating everyone or not? So patients with aneurysms can have bleeding, right? That's why we manage them with watchful waiting. Remember, a pseudoaneurysm is a false wall. Here, there's no vessel. This is a false wall that is encompassing this blood here in the femoral artery. And so this false wall and the the aneurysm, which truly have all the three walls, is the difference. Now, if there's a trauma or something else, then that tends to be a pseudoaneurysm. So that's the difference. Now, there are diseases, for example, segmental arteriomedialysis, that can result in sort of this formation of multiple aneurysms, especially in the middle-aged and elderly, and it can result in spontaneous intra-abdominal hemorrhage, and it's characterized not just by aneurysms, but also can have stenosis, dissections, and occlusions within the splanchnic arterial branches. So some of sort of these conditions, you will need to do embolization. And in this case, this is someone who can wait. This can even be done as an outpatient unless they're presenting in the acute setting of a hemorrhage. So something, just because you see it, it doesn't mean that you have to act on it. This is one of the toughest lessons of being an IR. Sometimes you don't look when you need to look, and others, when you see it, then you cannot move on. And so just be conscientious about that. Okay, I have another sort of bleeding case, and then we'll move on from bleeding. And I'll summarize sort of some of the things I think about. 23-year-old with abnormal placentation. Okay. No takers. So this is an angiogram. The catheter is coming from here. So this is a radio access. A pigtail doing an angiogram, an aortogram. And so you can see sort of just, I already gave you a clue because of normal placentation. You just see sort of this multiple vessels, and you can see the uterine vessels here. And then the delayed phase also has the just sort of this lots of pooling of blood here, just compatible with, placental flow. And so I was trying to lead you here to talk about postpartum hemorrhage. Is postpartum hemorrhage an emergency or not?
An emergency.
Yeah, so it's an emergency. Do you need to do a CT scan before postpartum hemorrhage?
No need.
Yeah, okay. So if in this type of emergencies, the role of imaging is actually, you have to understand if it's going to change your management. In this case, for postpartum hemorrhage, you're unlikely going to see any active extravasation. You're going to embolize anyway. And I hope that we have a lecture for postpartum hemorrhage. But the reason I wanted to discuss about the use of imaging, especially in the case of bleeding. Now, for example, sometimes when it comes to upper GI bleeds, people leave clips, and they will say, look, and this is even more important for us in Tanzania, where we may not have all the resources to do so many types of imaging. And they'll say, look, I saw the duodenum, that's where I was, I saw an ulcer, I saw a vessel. That tells that this is the gastroduodenal artery. And so we may just go in and do a celiac angiogram and an SMA run and just study that area, look at their clips, and make an intervention without doing any imaging. Now, for patients who've never had imaging, I do like to have some baseline imaging if I have time. Sometimes we do image patients on the CT scanner because most of our rooms are closed, and then move them to the angio room. In fact, some of the angio rooms in the world have both, it's called angio CT. You can bring the CT in, do the imaging, and then make your decision and start intervening. And for patients who have had surgery, I especially even if they had imaging before surgery, I try to look, because it's going to save me time in IR, where I'm not trying to do angiograms of every single vessel. And then the other places that I rely on imaging is if the history doesn't make sense. And sometimes if you think about the early comment of whether it's venous or arterial, that's important because especially in the case of liver disease, you're not sure whether you should be looking in the venous system, which would be really thinking about our tips, versus the arterial system. And so you have to be careful in terms of how you think about imaging and how it's going to help you in the short run, and will it cause even more delay for the patient. This is a sort of companion case, history of atrial fibrillation with a cold right leg. Is this an emergency or not?
can imagine.
Okay, so imaging here can help you a ton. So you have an abrupt cutoff. You don't see, at the SFA here, you don't see any other vessels in this leg here, right? This is chronic, peripheral arterial disease. And how do you decide? How do you evaluate the patient? Is there a classification system that we use?
Oh, yes, we're using the
Right. So you go to the patient, you look at for any sensory loss. Remember this in your medicine examination. There's fine and sensory looking, like we use the pinprick or the cotton swabs. Then you look for muscle weakness and you have a Doppler. And so you can look for your limb, whether it's viable, threatened, or irreversible, right? Because you have to classify well. And the reason why I show you this case is because the intervention is very different. Like if you have a stage 3 in this emergency, IR really should not be trying to salvage that limb because that's an amputation. And so just remind yourself about this classification. It's not a must really to cram these classifications. You just have to remember where to look for them. I know that this has been a big interest for Denise to say, why don't we link classification systems, for example, in trauma to outcomes? Like what do I do with this? But this is one of that type of classification. Everyone should be started on a heparin injection. And I thought that this is a good time to talk about other things that may happen. For example, making sure the patients are anticoagulated or factoring in the anticoagulation on on the impact of your emergency. For example, if you have an INR of 8, even in the acute bleed, you have to do something, which if you decide to give vitamin K, that really needs time to reverse the factors and and so it's not going to really be appropriate for your setting of emergency, and you may have to use, for example, FFP to help you reverse the patient in terms of an emergency. This also is a good reminder to discuss the role of other people. So in this case, for reversible damage, it's an amputation. So make sure you're consulting people who can bail you out or who can help you. Also, if you have sort of stage 2A is where we would be sort of revascularizing this because we have a little bit of time more than sort of when you have 2B where, the surgeons can also access it probably sometimes much more easy and quicker than us and, make an intervention. So just factor in sort of those considerations. I want to go back to have 5 minutes. This ones I'm just going to go quickly through. History of ankle fracture with right lower extremity swelling. The patient has a DVT and you're requested to put an IVC filter. Is this an emergency or an urgency or can wait? Okay. No attempts. Here's the IVC filter. So the IVC filters, there is an emergency when you have something called phlegmasia, cerulence dolens, and not just for IVC filter in terms of managing a deep venous thrombosis. And for the IVC filters, I try to prioritize them, especially when it's an emergency, when there's a clot in transit, because that big clot is going to go somewhere. For patients who already have documented PEs, I try to take care of those immediately versus patient who needs surgery and they just need a filter because they're immobile and, and there's concern for development of clot. That's a very sort of gray area of an indication for placement of an IVC filter. Or patients who are going to undergo surgery and they need to stop the anticoagulation so that they can go through surgery. They're high risk and then be resumed on anticoagulation. So those are cases where it's not really, it's not emergent in terms of the patient is going to die in the next 1 hour. They can, if they have a clot in transit and that clot goes to the pulmonary arteries, causing a big, massive PE. But I try to prioritize these patients, but I tend to be in the more urgent categories of taking care of them. Here is a liver cirrhosis with abdominal distension. This is TIPS, you can see the measuring pigtail here. Is TIPS an emergency or not? And when is TIPS, let me ask this, when is TIPS an emergency?
In patients with refractory upper GI bleed.
Okay. Yeah, so in the setting of GI bleed, you will have you will be requested to do an emergent TIPS. Remember that there are other things that they can start to do to like the Blakemore tube, which is used to like sort of gastric varices to try and give it manual pressure so that the bleeding reduces. Remember these patients with GI bleeds, just the same like the thrombectomy, will have high potassium, and that can also move their MELD score very high. And if that happens, they probably would be ineligible. Think about alternatives, right? So you can do a TIPS that people can also just directly embolize the varices and just, stop and use that. And that's why I showed this case. And most importantly for TIPS, when I see it as an emergency, I usually have to get imaging because you can be very surprised. And I have some cases of this where it ended up being an arterial bleed from the gastric arteries. And, and that would have ended up taking me to just a different position. Remember to take your echo in these cases, and also factor in the sort of like the severity of illness, and making sure that you have the necessary support to take care of these patients should they end up getting liver failure and they require a transplant. So left lower quadrant pain, this is an abscess. Is an abscess an emergency?
Then prioritize it.
Yeah, just remember to think about the sepsis, right? So the sepsis discussion, if the patient is septic and they have an abscess, then it's an emergency. If they're in SARS, you should really be trying to make sure that you stop that cycle of moving on into a disaster. And so just make sure that you factor that in. I think the one last case that I wanted to discuss and just highlight is around pulmonary embolism. Especially for thrombectomy. Remember, this is the cycle of death, and that is an emergency. And just make sure that you're factoring in the classification systems that help guide us in terms of what action to do to prevent progression. Finally, I'll show this as the last case. History of cancer presenting with head and neck swelling and difficulty in breathing. What's the diagnosis here? What vessel is occluded? There could be many.
Superior vena cava.
So when you have SVC syndrome, SVC occlusion, when can that be an emergency?
I think we can put it as an urgent.
I don't think it can be an urgent. It's either elective or emergent. Usually we take care of this elective. We wait for the attending who to come, we wait for the stents and all those things. When can it be an emergency?
When the airway is compromised.
For patients with SVC syndrome. Okay.
Yes.
So, right. And so this can happen even when you're putting a pot in a patient who has a mediastinal, disease. And so you can induce it, right? And it's because, when you have SVC syndrome, or it can also be because of tumor or something else. And when you have sort of SVC syndrome, and you can actually end up requiring an emergency just because of the airway compromise too. Okay, so just remember that, and in terms of evaluating the patient, and also remember our patients, the wards sometimes don't have lights, and we have a little bit of darker skin, so you may not really see the changes, and just discuss with the patients and their family. So when I think about IR emergencies, we didn't talk about the ACLS and the BLS stuff. because that should be a course that is done, but it's airway, breathing, circulation. You always have to remember to look at those. You have to look at the vital signs, and you're in a room, and that's why you should really see the patient in an emergent situation. Just lay eyes on the patient. It's going to tell you a lot. You should be thinking about how are you going to manage their airway. Sometimes when you flip the patient with urosepsis, then they decompensate and they completely don't have the same reserve. You should be thinking about how you're going to manage the sedation, whether you're going to use general anesthesia, moderate sedation, local anesthesia. Please, just because the patients are very sick, they still can feel pain. And so just because you're not trying to make them sleepy, think about pain management. Remember antibiotics and the appropriate antibiotics. Also ask about that from the wards where they come in from. I think about anticoagulation on both ways. Some patients may require to be initiated on anticoagulation. Others may require for you to correct their coagulopathy, and that affects your management. I think about where the patient is going to go and have that discussion early, so that you're not just sitting with a very sick patient, in your angio suite. Think about resources. This can sometimes guide, and this is the balance of the risk of waiting versus the risk of just moving ahead. If it's a very, very hard case, call for help. Think about the equipment and also the staff, and also factor in the next day. So some things are done at night because you're looking at ahead the next day, and the schedule is just impossible. So your urgent case may transition to an emergent case. We did not talk about consent, but you have to talk to the family, especially if the patient is not maybe in a position to discuss this. There is the concept of emergency consent that can be acquired by two physicians to save a patient's life. And, just talk to someone. And luckily in Africa, most of us will have, unless it's an accident, we'll have a relative with them. Just explain to them what's going on, manage expectations, because some of this can result in death. Think about documentation of your medical decision making. This is important because when things go wrong, sometimes people come back and play, the blame game, sometimes not just the family, but other doctors. And so just be careful. Remember know when to say no. Think about other clinical services. Help. This is where you wear also your radiology hat, where you help the primary team figure out, because everyone is desperate, right? They're like, no, as it's your tube, right? So help them figure out other sources that could also explain the patient's symptoms. So don't be so blinded and just accept everything that is in there. Be a good team player. Like I said, anticipate elective or urgent cases in the next day that could transition to emergencies that could help you, could make you make your decision making. And that's sort of a little bit of how we run our night float. And yeah, that's my thought process.